At this juncture, let me invite Honorable Dr. Charles Yume to come and give us a few remarks. Thank you very much.
When I joined Parliament, I made it, and I was made chairperson of the Health Committee against my will. I made it a point that, one, my phone will be accessible, and I'll try as much as possible to bring Parliament closer to the people. And that's why many a time you see it's either me or somebody I'll delegate in fora like this, in conferences, in symposiums, because we pick a lot of information from there. We pick the sentiments, the pulse of civil society, of the population. What direction do they want government to move? And that helps us in shaping policy, in advocating, in lobbying, and in strategic direction. Because the research you get from such fora, symposiums, conferences like this is well-grounded, and it's evidence-based. So in a nutshell, that's why we take a lot of our time to come in and listen in. Our roles as members of Parliament are simple: to represent people, to make laws, to appropriate budget, and to do oversight. Weddings, burials, those are secondary. That's what we call nyongeza. But the oath we took for, there are 4 roles. Now, I've listened in to the presenters, and I've also looked at the program, which is quite intense. And one of the action points, Professor Kirenga, is at a point in time, we can get a similar presentation for members of the Health Committee. And this time around, we are lucky that on the Health Committee, I think there are about 8 or 9 doctors, we have pharmacists, we have clinic officers, we have midwives, we have nurses, we have lab techs. About 20 of the 35, 20 are at least from the health space. So what you talk, we understand. And that's why in the 2.5 years, we have had some wins, of course some losses, but we have had some wins. So yes, we have listened in, and quite an interesting area. And the question is, what opportunities are out there for Makerere University Lung Institute? In my opinion, I would really want to see it grow beyond an institute. I've had the opportunity to track some entities in government that were once departments. If we look at Uganda Cancer Institute, it was a department. I remember the time of Professor... Pardon? No. He moved to UVRI. Mbide, the time of Professor Mbide. Cancer Institute was just a department in Mulago. But then later on it has grown, and at that time their budget was 333 million shillings. Now Cancer Institute is in place because of an act of Parliament, the UCI Act of 2016. For those of you who have been to the Hill, it's now the East African Center of Excellence. There's a lot of infrastructure development going on there, meaning they can fundraise, they can source for funding externally, and the rest is history. It started as a department, it is now in place by an act of Parliament, and it's now the Regional Council of Excellence. For those of you who don't know, 15% of the patients at UCI are foreigners. You have people from Congo, Sudan, Mauritius, and so forth. So I think the future is bright for the Lung Institute, and you still have the goodwill of COVID, because COVID was really a lung issue. That's where we were being hit first. So you have that opportunity. For us as a committee, ours is to support you. What is your strategic direction? Do you really want to remain as a small department, or do you really want to grow? The opportunities are many. The opportunity for legislation and policy, the opportunity for advocacy. In Parliament, we have advocacy groups. Good enough, we have champions. So for us, it's a matter of giving us this knowledge. I've told you that early next year, within the first 2 months, you can hold a similar conference just for members of Parliament, especially of the Health Committee, and we can co-opt other members. And you take us through this. The opportunity for appropriation, budgets are made in Parliament. That's where the loaf of bread is sliced. And once you bring us on board, then we can fight. I remember last year we had to put our foot down and try and cut some little money. It was not a lot, but at least we're happy that TB got the requisite money it was supposed to get. Issues like air quality monitoring, I think we can ensure that that really becomes part and parcel of KCCA. You people provide the research, you provide the how, but that should really be taken up and funded by government, the air quality monitoring in Kampala. Innovation, what innovations are out there to ensure that issues of lung disease are not very complex issues. I'll tell you, when we look at diagnostics, you're looking at viral load, CT scans, CD4 machines. I remember when CD4 machines were a preserve of Kampala. But now with innovations, the PIMA machine it has cascaded down to a health center 4. Before today's CD4, you had to bring samples to Kampala. So those are the innovations I'm talking about. Viral load. I think now we are still using hub riders to bring samples to CPHL. But yesterday, the president was commissioning a factory in Tinda. And among the rapid diagnostic kits they were making were viral load rapid diagnostic kits. So again, we are going to ensure that you can now do a viral load on Kalangala, in Buvuma, in Mayengo, in Koboko, and so forth. That should be the direction of innovation that we are going. And then, of course, CT scans. As government, we have tried to ensure now, at least at regional level, we can have CT scans. Of course, Professor Rodria, ours is still far-fetched. In West Nile, we are not yet on the national grid. So we have packed our CT scan. When the Ministry of Energy gives us reliable power, that's when we shall put our CT scan to good use. But the point I'm trying to make is that we are moving in the right direction. Parliament and science have to speak to each other to be able to drive policy and legislation. On the side of legislation, what opportunities are there that speak to lung health? The Tobacco Control Act, which was passed, I think, in the 10th Parliament, I'm not so sure if Ministry of Health has provided the regulations, because you can pass a law, but then government may take time to operationalize the law. So that is something that we are trying to do as a committee to ensure that the Tobacco Control Act is put into operation. Recently, we passed the organ transplant bill. Dr. Bruce and your team will tell us whether lungs can be, you can do a transplant of lungs, but for us, we did our part as Parliament. It's now an act of Parliament. Our flagship that we want to do is the kidney transplant. And for those of you who are aware, when Mulago was being renovated, it's not yet complete, but at least on 6th floor where we do dialysis, there were 2 theaters that were built purposely for organ transplant. They are 2 theaters juxtaposed to each other with a sliding door. So you harvest, you transplant. So we're just trying to ensure we complete things like the HVAC system, the water, and so forth. But in the last budget, we appropriated 1.5 billion shillings. We wanted to give Ugandans a present before Christmas. At least have 10 kidney transplants done. Because kidney transplant, that's a flagship. Once you do a kidney transplant, you know you've arrived as a country. So we're just trying to sort out a few things, but hopefully before the end of the financial year, we should be able to do these kidney transplants and so forth. The Public Health Amendment Act of 1935, we were able to review it, and now it is an act of parliament. It was signed by the president in 2023 in February. We made this act speak to non-communicable diseases. The Colonial Act was mainly speaking to infectious diseases because 100 years ago, most of the issues we were facing were infectious. Now, NCDs are biting, so we have to make sure that the current law now also speaks into NCDs. And some of these issues you're talking about, the cancers and so forth, would be captured. So we have impressed it upon government to invest in NCDs. NEMA. Sometimes when I'm driving behind these trucks, and I need to bring this to your attention because nobody has come out, you find the people, I think even if you went to Chitezi, what we call scavengers, the people who work in these rubbish trucks, there's no PPE and so forth. Professor Bruce and company, does it ever occur to you that the amount of pathogens these people are inhaling? 2 weeks ago, I was at a symposium on antimicrobial resistance. You imagine every day, that person in a truck collecting rubbish is being exposed to Klebsiella, E. coli, and so forth. At the end of the day, it comes back to you, Professor Warudria. You're treating something that is not being responsive to either quinolones, cephalosporins, and so forth. So sometimes let's not only look at the treatment aspect, let's go upstream and see how can we ask Parliament and policymakers, because we want to have a conversation with the Ministry of Environment. NEMA is under Ministry of Water and Environment, and say, if companies don't provide PPEs, close them, because people should be in gumboots, people should have gloves, people should have masks, people should have overalls. Stone quarries, you go to Banda, those women, unfortunately most of them are from my area, breaking those stones with all that silicone dust, pneumoconiosis, siliconiosis, and so forth. Then you get chest tightening in your 50s. So I think with the policies, the right policies, we can fix some of the issues, because most of you, I think, are looking at the downstream. For me, I'm preferring to look at upstream. Mining, all these underground open mines, you go to Mubende and so forth. So your conversation, the point here I'm trying to put, colleagues, in the spirit of One Health, stop looking at health as Ministry of Health. If you come up with issues, give them to the Health Committee, then for us we shall write to the line ministries and say, put your house in order, and so forth. As I conclude, the alcohol drinks control bill, which I'm sure most of you here may not want to hear, is before the committee. And that's why I'm running to Parliament. I have an engagement with the Ministry of Trade, trying to see the health people are looking at it from one facet, the trade people are looking at it from the economic facet. So we have to harmonize and see how can we make either the penalties a bit mild, because I've looked at the draft bill, it says bars should open at 5 and close at midnight. But we know how our economy runs. The night economy, very important economy. Muchomo, borders, prostitution, and so forth. I'm no longer looking at things as a scientist, sir. I'm looking at it as a leader. How many people thrive off this thing? Yeah. I think that's all I had to say. Then, of course, the occupational hazards. I really want the Makerere Lung Institute to help us in driving policy. You're doing very well when it comes to the science aspect, no doubt about that. But if you think there are low-hanging fruits that we can go and dam upstream to prevent all these cases from coming downstream, we're happy to do that. And that's why I'm saying next year, probably in the first quarter, if we can have something like that purely for members of parliament so that they understand. And then when we go to parliament, we can help you in driving the agenda. One, in terms of appropriating the necessary resources that you may need, but also in terms of coming up with policies that will help prevent some of these diseases. Like I've told you, these people collect rubbish and so forth. In my opinion, they are breeding grounds for a number of these diseases. Finally, the East African oil pipeline. Most of you have heard of gas flaring in the Niger Delta and so forth, and what it does to the community, to lands and so forth. Is it something that you people have been called upon to the Ministry of Energy to give an opinion? Because when the pipeline is being built from Hoima up to Tanga, I think there's a health component. All the camps, imagine the diseases, you know what it means at a campsite. STDs and all that, people are being paid per day and so forth, but also the gas flaring, the flaring of all these hydrocarbons and so forth. So I think also Makerere Lung Institute, through Ministry of Health or directly, you can write a paper on that so that you're also called to the table of men. It is very, 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 very important. Otherwise you'll get strange diseases coming up that side, and then in Uganda, we like to do things when they have happened. But I think for now, go and do a Google search and find out what happened. Oil flaring in the Niger Delta. And then you can come up with a position paper and advise Ministry of Energy. Otherwise, I thank you very much. This partly feeds into antimicrobial resistance. As the chairman of the Health Committee, AMR is my next war because I think it's our next pandemic. What happens when all these lung ailments you're talking about cannot respond to the antibiotics? So I would really also want you people to, as I help you, I want you to help me on the issue of antimicrobial resistance. When you pick some pathogens that are resistant, please let the line ministry know and see how we can tackle it.
So welcome to the podium, to the session, Dr. Rebecca Naatanda, who is going to handle pediatric lung health. Thank you.
Thank you, Dr. Simon Walisimi, and good morning, ladies and gentlemen. Let's switch to the children. We are all once children, so you might be wondering, we're talking about occupational lung diseases, occupational health, and keeping ourselves safe while we work. As children, we also work. We play, we go to school, and different things. So as we move in those environments, we need to keep those spaces safe for the children. And this morning I have the privilege to invite the team that is going to talk to us about pneumonia, the most common infectious disease in children. And we know that 50% of the pneumonia in children is because of the unhealthy environment they live in. So it's related to the topic that we are going to discuss today. So I'm going to invite our first speaker, Dr. Damali Nalwanga. She's going to speak to us about severe pneumonia, how it is associated with worse neurocognitive function among children living with HIV. Dr. Damali, you're welcome. Thank you.
I am honored to present some of the work we are doing as a pediatric research group at the Makerere University Lung Institute. And I will not waste any more time. I'll go straight into the presentation. Thank you. How do I? No. Where do I want this? Okay, thank you. All right, now HIV-infected children are surviving longer thanks to antiretroviral therapy that is now readily available at all levels of our population. However, neurocognitive deficits remain a huge challenge. And when I'm talking about neurocognitive deficits, I'm talking about how children learn, memorize things, how they plan for activities and then execute them, how they walk, run, crawl, and do all these things that make them children. But that's not just a concern at the level when they are still children. It becomes a concern when they are grown up and now have to be productive adults. So you can understand why it's a concern for us at a pediatric level when children have more neurocognitive deficits, because this means they will not become fully productive adults. And yet now with ART, they are going to survive longer, so they are going to get there. So we thought initially that these neurocognitive deficits are mainly due to HIV, infiltrating the blood-brain barrier, so you have intracranial HIV or HIV-associated infections for that matter. However, we've now seen that there are also other risk factors for neurocognitive deficits, such as malnutrition and poor family indicators, meaning that if a child is an orphan and doesn't have many people to interact with, they may have neurocognitive deficits. However, the contribution of extracranial infections like pneumonia to this neurocognitive display that children put up is not very well described. And yet pneumonia has well-known pathology that could come into play when a child is developing. Pneumonia causes hypoxia, which affects brain development. It also causes children to get admitted, so they have reduced periods of play and interaction with family and siblings, and also increases the risk of severe malnutrition, which we know is a risk factor for neurocognitive deficits. So what we did is to compare the neurocognitive function of infants living with HIV with and without severe pneumonia. So I'm presenting preliminary findings of the neuroempirical study, which is nested under a parent trial, the empirical trial. These studies are among infants living with HIV who are receiving antiretroviral therapy and have severe pneumonia. So they are being treated empirically for TB and cytomegalovirus pneumonia, which has been found in a lot of postmortems of children who pass on with severe pneumonia. And this neuroempirical study is funded by EDCTP and hosted at the Makerere University Lung Institute. It's a case control study. And our cases are infants living with HIV who have severe pneumonia and are in this trial. And what we do is enroll them into the neuroempirical study within 3 weeks of discharge. So when they are much better and they have reintegrated into the community and are playing, then we are able to assess them. And our controls are age-matched infants living with HIV who are attending routine care in HIV clinics and have not had severe pneumonia. So what we do is assess and compare their demographic, clinical, as well as neurocognitive function. And to test neurocognitive function, we are using a tool that was developed in the US but has widely been used in LMICs, that's low and middle income countries. And that's the Bailey Scales for Infant and Toddler Development 3. It's really children interacting with toys and other items that they would interact with in their family settings, as you see in the picture, a doll, a cup, a ball, and we just assess and score them based on how they interact with those. So we included 66 participants in this sub-analysis, and 44 of them, we had 44 cases and 22 controls. And majority are male, that is 56%, and the median age is about 6 months. There were no major difference in baseline characteristics, including age, gender distribution, prematurity, breastfeeding. All of these we know affect the brain development, but there was no main difference between these two groups. And their family care indicators, baseline hemoglobin, and the proportion of children on ART was similar between the two groups. the main differences that we picked up were that the children who had HIV and pneumonia were slightly more sick in that they had lower weight for height. That is, their nutritional status was poorer, probably because they had been diagnosed a bit late, and that is why they were coming with severe pneumonia in the first place. But the children who had severe pneumonia, and rather who had HIV but no pneumonia, had started ART a little earlier because they were stable, probably picked up earlier by the system. So they had started ART earlier and therefore had a longer duration on ART. So we found that when we compared the neurocognitive function, the population that had pneumonia did much poorer than the children who didn't have pneumonia. And as you can see, the pink are the neurocognitive scores, so you're really given a figure, and you can see that the children who had no pneumonia in pink are scoring higher than their colleagues without pneumonia. And this was across all domains of neurocognitive function. That is the planning and execution of tasks I talked about in terms of language as well as motor function. So we concluded from these findings that the infants living with HIV who had severe pneumonia had poor neurocognitive function in the immediate post-discharge period. And we are doing some follow-up studies to see if this difference persists or these children actually catch up later on. But what we can recommend from these findings is that any interventions that reduce the risk of severe malnutrition, rather of severe pneumonia, or the severity of pneumonia itself will be beneficial or might be beneficial in the long term and might reduce neurocognitive decline that is already known to be associated with HIV. Thank you very much.
Thank you, Dr. Damali, and kindly keep your questions and comments for the Q&A session. I now invite Dr. Fiona Icharohanga. She's also a pediatrician. This pediatrician on the stage. So she's going to talk to us about delayed healthcare seeking for young children with severe pneumonia, a study that was done in Mulago National Referral Hospital. Dr. Fiona, you're welcome.
Yes, so I'm going to tell you about a study we recently carried out in Mulago about delay in seeking health care for children with pneumonia. So globally, we see that pneumonia remains the leading cause, the infectious cause of death in children, especially under 5 years of age. And in Uganda, it is among the top 3 causes of mortality, that is pneumonia, malaria, and diarrheal diseases. Children who have severe pneumonia will end up with complications and even death if they do not seek care early. So it's the reason we carried out this study to find out the number of caregivers who delay seeking care and the reasons why they delay to seek care. We see that severe pneumonia is defined as children who have cough and difficulty in breathing plus any other danger sign. That is severe respiratory distress, having low oxygen, partial pressures, children who end up with convulsions because of the pneumonia, refusal to breastfeed. So the caregivers of these children are the ones we studied. And delay was defined as seeking health care after 24 hours of onset of the pneumonia symptoms. So the objective of this study was really to find out the number of caregivers who delay to seek care and the reasons that make them to delay, to explore those reasons. It was a cross-sectional study where we had 384 caregivers, and then we had 4 focus group discussions with these caregivers to understand or explore the barriers to seeking care early. And so the demographic characteristics of our care of the participants, we had majority being female. So 97% were female, and most of them were the mothers to these children. Most of these caregivers were up to secondary level of education, and we saw that more than half were coming from more than 5 kilometers to seek care. These caregivers were earning, the median monthly income was about 150,000 Uganda shillings. So those are the kind of caregivers we had in the study. We found that 54% of these caregivers delayed to seek care for their children. And the factors that were associated with this delay were 3 that we found significant. So those who came from more than 5 kilometers were almost 2 times more likely to delay seeking care for their children. And then the caregivers who were earning less than 200,000 Uganda shillings were over 2 times more likely to seek care late. And then the ones who first sought care elsewhere, that is going to drug shops, first going to a herbalist, going to the spiritual healers, for example, before coming to the hospital or health facility, they were about 2 times, 3 times and above delaying to seek care for their children. So the facilitators included those that were individual factors, like recognizing symptoms of severe illness made them to then seek care early, and those who had money for transport were able to seek health care early. For example, we had a caregiver who said that when she noticed that the child's breathing was tight, almost like grunting, which was initially not there. That is where now every parent realizes that, I need to seek care. So those that were able to recognize these danger signs were able to seek health care earlier. Then the ones that are under family relations, things like advice from friends and relatives, support from spouses. Like one of them said, I was told that pneumonia heals only when I quickly seek care. But when it grows, it is hard. So when they are advised right, then they seek care early. Then the health facility factors, things like when you have skilled health workers in the hospitals, then the caregivers trust the health workers and will come to seek care instead of going to other places. Things like early identification of the danger signs by the health workers and then early referral will make the child be able to get care early. So we had a caregiver who said, we went to the health worker at a drug shop who said that the child's breathing is really not fine and you need to immediately take the child to a skilled health worker in a hospital. So those are some of the factors that make them seek care early. Then the barriers, we have barriers that are to do with the decision to seek care, and then those that are to do with reaching the health facility, and lastly those that are under, when you reach the health facility, how soon can you get the help you need? So decision to make care, we have things like limited knowledge of symptoms, low level of education, unsupportive spouses. All those affect the decision of a caregiver to seek care. For example, one said, I decided to buy some Panadol to give him and see. When it came to the night, the child developed a fever. I continued to give some Panadol until later when I went to a hospital. So not having the knowledge affects these caregivers and so many others. And then those that affect reaching the health facility, things like transport means. Some will opt to first buy drugs from drug shops as they look for money to then go to a health facility. And then once in the health facility, some of them get delays because they are not referred early enough. For example, if they go to a drug shop and they cannot manage a child with severe pneumonia, if these people do not refer early to hospitals, then the children end up delaying to get the care they need. In conclusion, so delay in seeking health care remains a problem, especially in low and middle income countries. We see so many factors, including long distance to the hospital, delayed referrals, the family income, the education level of the caregiver, recognition of symptoms and their severity, and even family support. All those things influence prompt care seeking. And so we still need to do research in effective interventions to be able to improve care seeking early. And then we mostly need to create awareness in our caregivers on the symptoms of pneumonia and the need to seek care early, because then we shall not have complications from pneumonia. Thank you.
Thank you so much, Dr. Kena. You can take your seat. And thank you so much, audience, for really being interested in the children of Uganda. I'll now hand over the microphone to the chair organizing committee or organizing for this podium. Thank you.
Thank you, Dr. Rebecca, for the session. Ladies and gentlemen, for now I invite you for the tea break as we have a photo moment.
Occupational lung disease, protecting our lung while we work. That is a brief outline of our talk. I will define occupational lung disease and try to express the different types of occupational lung disease. There are as many as we may have occupation. And then I will zero down on silicosis. As the Honorable Member of Parliament earlier mentioned, it seems to be one of the most prominent occupational lung diseases. I will give you a slight historical perspective. And then we did conduct a pilot study at Mulago, and it will help to bring home what this means in terms of patient care. So occupational lung health is a global problem, and the International Labour Organization states this as one of the fundamental principles that safety and healthy workplace is a mandatory component. So a healthy work environment is very critical. Often the hazardous materials in this workplace may not be very clear, and you find individuals working in hazardous environment for long hours. Like you heard the story of people on the garbage truck collecting garbage, oblivious of the risks that they stand by working in that environment. It is therefore our duty as physicians and as people who are enlightened to raise awareness to provide a safety work environment. The American Lung Association defines occupational lung health as lung conditions which are caused or made worse by long-term exposure to irritants at the workplace. And the irritants are several. Dust particles, which are the most notorious, chemicals, fungal spores, droppings, etc. The important thing is there is no cure for most of the occupational lung diseases. So as the Honorable Ayume did say, you'd better move upstream and prevent occurrence of these occupational lung diseases. So if you control exposure to the irritants, you may slow disease progression and lessen symptoms and improve the quality of life. But you may not go back to the normal situation. Other risk factors are smoking, which actually can worsen this. We do have several types of occupational dust exposure, causing what we call dust disease of the lung. So these range from silica, cement, metal particles, cotton, sugarcane, coffee husks, and garbage that we are talking about, wood dust. So whatever occupation you think about whether it raises dust in the environment and whether this dust may be hazardous to the worker. So several occupations from mining to construction to farming all present some risk. So current challenges and trends. The first world is well ahead of us in many of these aspects. In the 20th century, coal and silica were the main risk factors for occupational lung disease. But because of the interventions, that has significantly reduced. But that, I think, is where we are at the moment, where there's excitement in discovery of several minerals. There are ventures in maybe constructions and so on. But in the West, like according to this review, in Europe, now the allergens are a little bit different. Baking, food processing, exposure, irritants in the cleaning industry. It is because they have moved further and they have mechanized many of these processes. And they have installed effective preventive mechanisms which monitor the level of dust and level of exposure. And of course, the current trend is campaign against reduction of fossil fuels. Those all are taking them in a different trajectory. But they are not immune from occupational diseases. Work-related asthma is common, not only there, but also in our environment, where the environment can either trigger asthmatic attacks or sensitize you to develop asthma. There is exposure to sensitizers that are included in spray painting. There's a proliferation of garages which do a good job repairing our second-hand vehicles. And they do a lot of spraying, and many of those people get exposed to some of these chemicals and sprays. And several detergents that come on the market, some untested, some without known side effects, predispose people to sensitization. There are other exposures to vapors, fumes, and so on, and may lead to chronic obstructive lung disease. However, in the context of tobacco smoking and biomass exposure, it may be very difficult to disentangle this as a cause. And our colleagues earlier on did talk about occupational lung cancer and asbestos, much as it is banned in several places since 1999. It is still the leading cause of lung cancer, even in the developing world. Allow me to dwell on silicosis. And silicosis, the Earth's crust, that is, if you drill 20 kilometers from the Earth's surface, contains 80% silica. So it is ubiquitous material. Okay, so silicosis is an important topic. So this is a reversible fibrotic lung disease caused by inhalation of silica particles. And this has increased over time astronomically by various amounts, like is stated at 66% increase from 1990 to 2017. But we do not have enough information in Africa to document exactly the burden of silicosis. The crystalline silica is thought to be the most toxic form, and silica by the International Association for Research on Cancer has been designated as a human carcinogen class 1. That means there's a definite association between silica and lung cancer. And it is usually associated with progressive disease and is associated with increased incidence of tuberculosis. So for the medics, that is a plot showing somebody who died of silicotuberculosis, and you can see in the upper zone, the lungs are completely destroyed by tuberculosis, and what remains of the lung is fully occupied by silica particles. So you, in effect, have no breathing space left. Silicosis is a disease of antiquity. And for people who belong to the honorable profession of medicine, Hippocrates, before Christ, already described a condition of breathlessness among miners. So this is not a new disease. I saw here Dr. Sechimbi, who is more or less the father of occupational health in Uganda. And there are people like Agricole Ramazani who described in the 16th and 17th century silicosis among populations. And Agricola, who is called the father of mineralogy, in his dissertation, he put out a very detailed explanation of where you can get minerals, how to mine, the engineering works, and the risks in his treatise. And this was translated by the 31st President of the United States, who was also an engineer and interested in mineralogy. So this information is available, and it has been examined. So mining and prospecting are not a matter of luck, but hard work is needed and specialized knowledge is needed. So we have certain challenges with that, but I think we will keep on learning. So in part of his observation, he noticed the association with dust and difficulty in breathing, corrosiveness in the lung, which I think it was really due to damage as a result of TB. But then they did observe that a woman in her lifetime would marry up to 7 husbands, because most of these men would die prematurely because of exposure to dust during the mining activities. The other person who enormously contributed to silicosis and occupational health is Ramazani, and he detailed the hazards of chemicals and metals in lung health. And he did introduce one important question that many doctors should ask about their patients. It's not that they're interested in the money you make. That may be part of the reason, but it is important for your doctor to know where you work in the work environment, because that's very critical, especially regarding prevention. I think I will skip the silicosis pathophysiology, but silicosis may present simply just with an irritating cough. Several people visit their doctors just with a cough, persistent cough, which you can't establish the origin of. But it may later on develop into other things. However, continuous exposure may lead to complicated silicosis, and you develop lung fibrosis, scarring of the lung in lay terms, and reduction of lung reserve. The worst case scenario in silicosis is what you call progressive massive fibrosis, where your lung tissue continues being scarred and it just becomes a bundle of hard fiber, which the lung is porous, but with continuous exposure, it becomes scarred and non-functional. And you may have what you call accelerated silicosis. Normally, silicosis happens when people are exposed for several years, 10 years and above. But we have observed accelerated silicosis where within a short exposure, somebody may develop scarring of the lung. So I would like to talk a little bit about our situation. And the known risk factors include mining. They talked of gas flaring, which is coming soon with a pipeline, quarrying, construction, cement works, pottery, the steel and rolling activities, all predisposed to silicosis. Uganda is endowed with several minerals. We have colleagues from other industries. So indeed, there's no shortage of minerals. However, this article by Fisher and others looked at the various sites, particularly for gold mining. There were 4 particular areas they saw: Southwest, Mubende, Busia, Karamoja, and most of the work is artisanal. And I will show you some pictures, what we mean by artisanal mining, which is small-scale mining activities. It employs up to about 400,000 people. And some risks exposed, apart from lung complications, issues of HIV, and other inequality issues also involved. But there's minimum sensitization. So part of the artisanal mining, it's really subsistence mining, laboring under archaic and difficult working conditions, poorly ventilated environment, overcrowding environment, and poor health-seeking behaviors, usually in those communities. Other risks are our construction industry. The country has a 2.4 million housing deficit. So everybody is trying to construct, and this deficit is growing annually. In my search, unfortunately, I did not find a lot of information regarding occupational lung health in the construction industry. And yet, that is a very important potential cause of lung complications. One thing we love is beautiful kitchens, and these are a very important source of exposure to silica, because stone is reconstituted and combined with polymer resins and heated to create these beautiful bench tops on which we do many of our processes. So it also leads to silicosis. In one study, about 100 people were followed after exposure to silica from this artificial stone. And at the beginning, 93% had simple silicosis, which I said was just an irritating cough, and really you find nothing else. And they all stopped working in the stone industry. However, the disease progressed, and you'll see 4 years down the road, initially you had 94 that were 6% had severe lung damage, but after 4 years, that 6% came almost to 40%. So even when you stop working in some of this environment, the fibrosis, the lung damage continues, and it may be irreversible. So a small pilot that I observed as we worked at a tertiary referral place was, we noticed that several patients were not leaving the hospital. And the main challenge was they needed oxygen. oxygen, as many do know, during COVID, is not easily accessible, is expensive, and difficult to maintain. So at one point in time, out of a 30-bed capacity, about 8 to 10 of the beds were occupied with people who were simply not going home because the only reason was a need for oxygen. So this, it made us explore and understand what were the issues causing these people to be admitted and what is the impact of silicosis on these individuals. So this was a descriptive study, and we used a brief questionnaire, and confirmation of silicosis was done using standard tools. So this, over 1 year, these were about 17 people. Median age is 42 years. This is the average adult male who is in the productive age group. A quarter of them were smokers. And most of them had had some symptoms for at least half a year before they were diagnosed with silicosis. And they had been admitted at least twice before a diagnosis of silicosis was made. And on average, they spent at least 3 months in hospital, but there are a couple who have spent more than a year in the hospital because there's really nowhere to go. And when you discharge them, that is synonymous with a death sentence. So that is a summary. And regarding the occupation, 7 of them were involved in artisanal gold mining, and yet they could not afford oxygen to keep themselves at home. Construction industry, farming, some were casual laborers in the shop, and stone cutting that we talked of, artificial stone, also was involved. And then one person was involved in steel and tube industry. So the symptoms mostly was cough and difficulty in breathing. And of course, this, just I put it, this is what a normal CT would look like, because radiation, when it passes through the lungs, it appears dark. However, this is the lung of one of the patients, so you can see the darkness has disappeared. He was involved in construction industry, painting for over 17 years. Now he can't live without oxygen. The next one was a 27-year-old who was a casual laborer in a hardware shop, and he suffered tuberculosis. After being treated for TB, he did not improve. But you can see the white spots in the lung. The lung was completely occupied by these silica particles from the cement that he ferried. And the last one came from the gold mining area, and this is what we call progressive muscle fibrosis. The lung tries to coalesce almost into one ball. The white patches that you see, there's no way you can breathe through there. So he did work in Mubende, and he ended up with a lung that was that, and I think he actually did not survive the admission. So silicosis is a problem, and we do see it, so we thought documented this. So most of the people could not afford home oxygen. So that was a big issue, social problem, economic problem. So most of them were not able to support them and their family, and they could not pay fees, and they felt disabled. 2 now, some were deceased now, but 2 are unable to leave hospital. So most people presented late. So we are seeing the tip of the iceberg. So this advanced, complicated silicosis in need of long-term oxygen treatment. And gold mining and construction were the commonest economic activities. And of course, we saw that there was a delay in diagnosis of these individuals. So In brief, silicosis is an important cause of catastrophic health expenditure and chronic morbidity among economically productive Ugandans. And there's a knowledge gap, and the need for oxygen is a major challenge and leads to prolonged hospitalization. So there's an important need to address this problem through early detection and prevention, but also those who are already affected need to be rehabilitated. Oxygen should become affordable for majority of people, whether it is through national insurance scheme or something, it would be desirable. And one sector cannot go it alone. We need multi-sectoral collaboration, and I think Dr. Chimpi will allude to this. Under Uganda National Association of Community and Occupational Health, we have assembled a task force which is brainstorming to see how we can involve additional stakeholders to kind of address this problem. And the International Labour Organization is a detailed brief on silicosis. It is admitted that this is an incurable disease, but we need well-organized preventive programs, laws and regulations, systems of surveillance, and appropriate technologies which can reduce dust exposure and protective equipment where necessary. So I acknowledge all the stakeholders and the organizers of this conference for this. Yeah, thank you.
This is a very recent case that was seen at our National Referral Hospital. A case of a young man working at one of our milling factories who was come down with lung fibrosis and currently oxygen dependent, as I heard. So these things are real, and we need multi-sectoral action to address them. We have some of the people online. We have Professor Peace online. I don't know whether you can hear me recognizing you. Professor Peace is a founding member of the Lung Institute, one of the forces behind what you are seeing today, and is a board member. The Lung Institute has over 25 national and international collaborators, ladies and gentlemen. We have Professor Rodney Falls, a member of the Institute Technical Board of the Lung Institute. We have Dr. Frederick Van Germaat from Belgium. He's also a member of the Institute Technical Board. We have for Dr. Winters Mtamba. He's also a research fellow at the Lung Institute. So colleagues online, thank you for joining in. We also are joined by Honorable Kamara Nicholas, I think, a member of Parliament. So you're very welcome. We are trying to disseminate evidence concerning occupational lung diseases, and we just received a keynote address from Professor William Orodria. It's just going to be a 5-minute story, but sometimes good to put live stories behind some of these statistics. So you're welcome to the podium. Thank you.
Thank you very much, everyone. My name is Seba Michael Collins. I'm a 5th year medical student at Makerere University. So I'm really privileged to present at this conference. During my rotation and then internal medicine rotation, I came across a very interesting case. So this was a 42-year-old female. She was a mother of 5 and she was previously employed at a wheat factory for a period of about 1 year before her illness started. So this lady, she came in with worsening on and off dry cough with difficulty in breathing for 5 years. So before her admission in Mulago, that was 2 months back, she developed difficulty in breathing and dry cough worsened. And they were associated with easy fatigability, and her difficulty in breathing also as well as worsened whenever she was exerting. So when I went ahead to check out other systems, there was basically nothing remarkable. But in her past medical history, she had been in and out of hospital during this period of 5 years. She was mainly being treated for pneumonia, but she really had no improvement in her symptoms. And a year back, before being admitted in Mulago, she had been clinically diagnosed with TB, and she had been on anti-TBs, but she also had no improvement. Yes, so she had never used cigarettes, no smoking. She had no history of alcohol use, and she also did not have any history of cooking in small spaces using firewood and charcoal. So when I did a brief examination about this patient, briefly, before my colleague comes in to discuss the CT findings and X-ray findings, I'll just give a small brief summary about examine findings. So she was a sick-looking lady. She was tachypneic at 26 breaths per minute, and she was on oxygen saturating at 90%, 5 liters per nasal bronch. Significantly, she had reduced air entry with dry crackles. So with that, it made us start suspecting possible pulmonary fibrosis. So we wanted to do some investigations. So at this point in time, I'm going to invite my senior, Dr. Frederick, first year resident of internal medicine, to take us through that. Thank you very much.
Thank you very much. I wouldn't have asked so much, but kindly put your hands together once again for the 50 medical students who put this together. As introduced, my name is Dr. Frederick Bakandonda. I am a first-year resident in the Division of Internal Medicine at Makerere University, and we're part of the team that attended to the patient. So just to highlight that with a lot of strife, and when I say with a lot of strife, it means that this is an investigation that was requested for multiply before we eventually got the test done with the help of Professor Bruce Chirenga. And it is not the clearest of images, but you can be able to identify that in summary, we have in the subpleural areas, we have both ground glass opacities and patchy opacities. And we note that similarly we have interlobular sort of like fibrosing in the lower areas of the lungs. Now, this is a diagnosis that was arrived at after over 5 years of the presenting symptoms. And what we intend to highlight with a case such as this is that, one, the diagnostic acumen all over the country cannot be the same as at a national referral hospital. This is a patient who had very minimal exposure, just over a year in the wheat factory, but we are seeing that they have extensive lung disease. The exposure of wheat and flour, whether it's from milling or it is from the harvest, that is to the grains, basically the dust, it is dangerous, but the spectrum to which is not really known to us all. Someone would have expected that if we were to have some dangers here, maybe she will present with something as light as just a little bit of allergies. If it extends, maybe she gets a hypersensitivity pneumonitis, which if we withdraw the exposure, she's likely to get better. If it gets even worse, maybe she gets an occupational asthma. This is a spectrum of illness that this lady was exposed to. But she ended up at the last end of the spectrum with irreversible changes in the lungs, which have currently made her oxygen dependent. The highlight from our talk is that you can use the stop principle to be able to bring a clause to the people. Because, you know, in Uganda, based on the poverty and our socioeconomic status, we're already highly exposed. This lady is already someone who was exposed to biomass fuels at her home from childhood. So that is a risk that is further compounded by occupational exposure. So when I say the stop principle, we mean systemic, technical, organization, and then personal aspects to try and stop or mitigate the exposures. Not all of us, not all of the people that we know can have access to a professor of medicine in the division of pulmonology to be able to arrive at a diagnosis such as this. So wherever we are, in the regional referrals, in the health center force, one, our part is to be able to think about these diseases. Think to ask about occupational exposure. Two, when we cannot be able to identify the cause, quickly refer. The case clearly highlights that the patient has been treated multiply for different diagnoses. A pneumonia this week, a pneumonia the next month, even had a full course of antituberculosis medications instituted, still with no improvement until she reached the national referral. So we can do better. For policymakers, we appreciate your availability here, because this can stem from top coming down. Much as the stop ends with the person, it starts from above, organizational, then individuals. So I'd like to thank the Lung Institute for accepting us to make this brief presentation, and I hope it brings context to the discussion and the purpose of this symposium. Thank you very much.
Thank you. Daktari is in training. So the take-home message is that these issues are with us. Unfortunately, we are only handling the tip of the iceberg. I think due to popular demand, we need this message to go out. What is it really? Sorry? Ah, okay. So where do you work and are you protected? Okay. So we need this to go out to our public.
I want to welcome you, first of all, to this symposium, which is our second, and I will talk about what this symposium is about today. But welcome all of you. So I want to thank the organizing committee, Simon and your team. We really appreciate for putting up this symposium. You know, these days there are so many meetings, so many. So to catch these people and put them here is really a huge effort. Because the Lung Institute is only making 8 years today, I thought I would show you 1 or 2 slides about the Lung Institute. If you can, okay. So the Lung Institute started 8 years ago. I'm going to make the story brief. This photograph, the people in this photograph 8 years ago in a council room at Makerere University, if you were here, you could stand. Those ones who are here, they are not many. Yes. So we have the 2 people who were here on 30th November 2015 in a council room when the Vice Chancellor, who is in that photo, Professor Dumba, allowed us to start this institute. And we really thank him so much for that. I think the other slides, this one you've seen on our posters, and this is where we came from. Professor Dumba asked me, when people want to start institutes, they come and show me $1 million US. You don't seem to have. I told him to start an institute, you need scientists, and I had them. So he was convinced quickly, surprisingly, to approve. The scientists who are there, when we were standing, you can stand up, because that's all we had. Rebecca, Wincy, our MC chair of organizing committee was there, and the others. At that time, we thank Mulago Hospital for giving us this room. I don't know whether you can see that room there. So in that room, in nuclear medicine, I don't know whether you can figure out the tanker there. There's a tanker in the small room there. That tank was for nuclear material used in imaging, not for dangerous. And then later the university, the College of Health Sciences, thank you very much, Professor Ibingira, they gave us the next animal house, which we transformed into our home. And the minister accepted, the Minister of Health, to come and open the reformed animal house. Our principle was still, when you have the scientists, you can have an institute. I will just skip these ones. These ones, I don't want to waste time. This is our impact. It is in the folders. You can look at it. One thing we are proud of are the young scientists that we have. We have over 200 now. And of course, we contribute to tax and NSSF. But also, I become very happy when I see young people presenting dangerous science. And we have them who are doing a lot of work. I will leave this alone. Just to say that we have a new strategic plan, and this is where we are going. This project actually was supposed to break the ground today at MLI at 8, but approvals did not go through. So this project is ready. We thank Mulago Hospital for giving us 1 acre of land and for all the partners. And probably in 5 years, we will be in this place. Honorable Ayume has gone away. Honorable Kamara, you know our story. We really want to make a national institute. Honorable Yonga, please join the group. So we make a national lung institute because the burden of lung disease is so big to be handled at one institutional level. The university has tried, but we are pushing for this. Honorable Ayume told us, I think Honorable Yonga, you were here, that we need to get an act of parliament. We don't fear danger at MLI. We are going to give it a shot. So this is, that is the project. It's a 2-in-1 project with a hospital end, which we are calling the Center of Advanced Pulmonary and Intensive Care Medicine, but also the research end. The project we need is only 13 billion. And the Honorable Kamara, this one you can just give, appropriate. We don't even need to start burning our fingers. Yes. Please clap. People this side. Yes. But I also want to tell you, as the institute and the university, we have our 3 billion in the account. That's why we wanted to break the ground. Because with the honorables, we have to show them something coming. So we are going to break the ground with what we have. But please, let's not burn our fingers looking for this money while handling a national problem. I think this one is done. So I'm going to go to my third item about the conference of today. We chose in our second symposium to highlight occupational lung health. And actually all health, by the way, not only occupational. And Professor Urodi and our students have highlighted it. But let me tell you, the epidemiology of lung disease is changing. When you go to the ward, you see it changing. You don't need statistics. Actually, I tell people, I know our colleagues from public health and they want statistics. You don't need. If something is changing, you will see. We have moved away from admitting only TB. You now see lung cancer, almost #1, and this lung fibrosis. So, and the people tell you, like the case presented, just working in a wheat factory. But there are people working in more serious things. Last Friday, one employer who I really want to commend drove all the way. I will mention the place, for no fear of conflict, from Jinja with his 2 employees. I will not tell you the industry. And these people could not breathe. And the man was concerned. I thank him for bringing them. But when you looked at their lungs, young men, 26, 32, the whole lung is stiff. So we thought that we need to bring this, and we thank you, members of parliament, for inviting us to present to you this again. I think my team will consider breakfast meeting early in the year for only the members of parliament, so we can discuss this. I want to leave you with a quote. This quote is from a gentleman called Harry S. Truman. It is not me who found it, I just stole it from Dr. Lukande, but I liked it so much since I saw it. Truman said, "It is amazing how much you can accomplish if you do not care who takes the credit." It is amazing how much you can achieve or accomplish if you do not care who is going to take the what? The credit. This is our driving force at MLI. We leave these young people come and be in the driving seat and travel and present such that they can become independent scientists. I want to thank you for coming to this symposium, which is the second. And at this time, let me invite my boss, the chair of the board, to give his remarks. Thank you very much.
Thank you, Dr. Bruce, for the great remarks. So our chief guest, the representative of the Ministry of Labor, the honorable members of parliament, today we are blessed to have many MPs present, and we don't take that for granted. Thank you for giving this great attention. Our senior colleagues who are around, ladies and gentlemen, my name is Ibenjira Charles, and I am the chair of the board. Just allow me to appreciate all the other members of the board who are here. And may I request Professor Sewankambo to stand up. He's one of our board members, seated there. Thank you very much. We have Professor Tis, I think he's online. I hope he hears us. Dr. Bruce is here with us, and the others are with us in spirit. That is the team we work together to drive the agenda of the Lung Institute. So let me use the chance also to welcome you all to this symposium, the second of its kind. I know this is a very busy time of the year. People are preparing for Christmas, but on the other side, people are preparing for exams, both to be examined and also to prepare exams. So to have such an audience, I think is a big attention to lung issues, and we appreciate you for that. I also want to appreciate the organizers and to thank you particularly for this theme of today, occupational lung health, protecting our lungs while we work. I think this is very, very topical and relevant, especially in this era in Uganda where we are moving from the usual business but going into serious business of industry and doing work to make a living. There are many Ugandans who are involved in lots of occupation, but who don't actually appreciate the dangers they can get from these kinds of work. Their focus is earning a living without knowing that actually in so doing you can actually endanger your life. I see many people at workplaces, building sites. There is a danger, I think, which you have not talked about in agriculture. These days there is a lot of use of herbicides, and each time you are walking you pass men and women holding spraying cans, and they do that the whole day without even a mask, without bothering. We don't know the impact of these chemicals on our lungs, and I think there is going to be an explosion because people no longer weed. They use herbicides to kill the weeds, to spray the insects, and so I think this topic is very very important. So I want to appreciate the organizers. The CEO of the Lung Institute has said a lot, and therefore that makes my work easy. But for us, the work of the board is drive the strategy of the Lung Institute. And for the last 8 years, we've been doing this. And probably this is why we have reached where we are, working steadily with our management. And really, we need to appreciate our management for making these great strides. Really, the Lung Institute is just a young institute, 8 years. If to a child, maybe would be in P2, P3. But what we are doing is for a very big adult, maybe at 40. So thank you very much. So our main vision is high quality lung health research that integrates disease prevention. And I think you see what we are doing. This poster they presented, if you take it seriously, you can save very many lives. Most of you who drive around Kampala, you saw them yesterday. I think that was a plus for you. Disease prevention is very, very important. And I want to urge us, what we have started now on occupational health, we should drive it even more. We have the MPs here to support us, and we should give them evidence to use to enact the necessary laws to help us to move. Because we need to protect people. That will help us to save a lot of money and to save a lot of lives. But with that vision also, we do a lot of training. The CEO has told you the number of people who have been trained, over 2,500. That's a very big number in a very short time. And over 140 professionals. We do a lot of clinical care. 8 years ago, there was no specific place for caring for specific or special lung illnesses. Today, when you go to Mulago, you'll be welcomed and you'll be taken care of. So there is no need of flying people outside. I think we have the bare minimum facilities, but we ask that we get the state-of-the-art facilities to take care of Ugandans. And this building that has been shown here will have all the facilities to do that. The chair of the health committee was concerned that are we going to do are we looking at lung transplantation? Yes, that is one of our strategies. once that building is put up, definitely lung transplant, like these people you have seen, if the whole lung is damaged, you can't live. But there are many other Ugandans who die when they still have very clean lungs, which we can harvest and donate to these Ugandans who need them. And thank God, the act or the law on organ transplantation is on. So that roadblock is off. So we are doing a lot of clinical care, and our center of focus is our patients. Patients and patients. Also, we don't want to stop at that, but we are doing research to push innovation. And very soon, I think management of Lung Institute should also think about developing drug development to treat some of these unique diseases. So we should have an arm on drug development so that we can also cut on that cost, but also an arm on implements which can protect people. Like Professor Oldia, you are talking about occupational hazards. But what should these people do? I mean, they have to earn a living. They have to go underground. They have to spray. They have to work in these industries. If you go to most of these grain mills, people are inhaling dust every now and then. Go to Hima, go to Tororo. What should they do? We should be the one to come up with those innovations to protect the lungs, and those should be our patents. So I want to urge the Lung Institute to have that arm also, so that we can prevent, we can protect, and we can promote the best lung health in this country and the region. We are making a lot of contribution. I think Professor Bruce did not talk about the publication and the knowledge we are generating. I think most of that knowledge should be compiled as policy briefs to make sure that we impact the policy makers, both locally here for our existence and also worldwide. But otherwise, we are contributing a lot of knowledge. And I'm really impressed to see that the people who are being trained are also actively involved. So the Lung Institute is doing a lot, and at this juncture, I would like to appreciate all those who have been around since it started, who have given us support, and specifically I want to thank Makerere University. Professor Dumba played a very big role, because no one would allow that institute to begin in that place. But I think he had a lot of trust, and we should always appreciate him. Secondly, Mulago National Referral Hospital, and also the Minister of Health. Right now, we are doing our best to formalize that relationship, and I think it's almost done, and we appreciate that. They have given us land, and so we are part of the big service deliverers on the hill. But we also want to appreciate all our partners. We've had many partners locally and internationally. They have played a very big role. Many of those we work with them in research, in clinical care, and they really help us to go on and to move on. And so we appreciate them so much. About going forward, I think we have already said with this building, we are moving forward. But I also want to assure you that there is a lot of trust on the Lung Institute. You have seen government entrusting us to take care of the COVID-19 surveillance and care. That was no mean trust. Government trusted us to handle Ebola. That was very important for us. And now the Lung Institute is going to be a center for vaccine trials for WHO. That is very, very important. If you go today to the Lung Institute, you'll be shocked and surprised. So what I would like to say is that we are moving forward and very fast, steadily and strategically. And therefore, this meeting here is just a one-off. Be prepared for more greater things, including providing the necessary care, but our biggest efforts will be on prevention through research, and also to help those who are already sick to make sure that they get a good quality of life. And our focus is on training. So research goes hand in hand with training, and we shall train Ugandans to make sure that we build capacity or we improve capacity, so that wherever a patient with lung disease lands, whether it is a health center or a national referral, will be able to get attention before they are even think of referring. So that is our focus. I want to thank you all for coming. Please, I want to wish you a nice listening, and please, for the honorary members of Parliament, we really don't take your presence here for granted, and we want to invite you to fight with us. You know, we have to keep our lungs healthy. People didn't know that oxygen was very important. It was only after COVID that you could even not get oxygen. So when you move around and you are breathing normally, you don't realize what would happen if you could not breathe well. And therefore, we need to make sure the lives of every Ugandan, the life of every Ugandan is able to breathe well and healthy. Thank you very much for listening to me.